soon. So my presentation is on my project, which was a near-peer surgical simulation education program for orthopedic interns. I have nothing to disclose. Just a brief overview of my objectives and an overview of my slide deck. The objectives of my talk, I hope by the end of this, you'll be able to better understand the benefits of near-peer teaching in a technical skills curriculum, especially as it applies to simulation. And I hope that we'll be able to have an improved understanding of the process of creating a formal simulation curriculum. I know this is a big learning experience for me, kind of being the first time boots on the ground doing something like this. And I would appreciate any feedback or suggestions from the audience on this stuff as well. To get through this, we'll briefly touch on the utility of surgical simulation, the benefits of near-peer education, and then kind of talk through how I developed our curriculum and the next steps that we're going through in instituting this. So technical skills training is, well, surgery at its heart is a high performance technical skill. There's a lot of cognitive aspects and a multitude of external influences going into it, but much like other technical skills such as basketball, for example, it's very important to establish fundamentals before you can kind of continue to advance and master the craft. For example, when fixing a fracture in orthopedics, you're going to be using plates and screws, but you need to know how to put in screws before you go to the advanced building of constructs and those types of things. In sports, we often work on these through drills. If anyone's done sports, you're basically repeating a very simple task until the point of mastery, to the point where it's second nature to you. Unfortunately, in surgery, especially in orthopedics, this is not always feasible in the operating room learning environment. You can't repeatedly put in and take out screws on a patient until you're proficient at it. You kind of have to go through many, many surgeries, doing all parts, not being able to specifically drill down and focus on one in specific particular. And ultimately, that's where some of the benefits of simulation come from, being able to take technical skills away from the operating room environment in a practice environment. Simulation has been applied to a number of high stakes environments. I don't know if you guys have kind of heard the news story about the plane that lost an engine that was able to land safely, thankfully. But we borrowed a number of concepts from flight education training in surgery, such as the checklist system, which has dramatically reduced operative errors. Simulation is another thing that's actually very widely used in flight training. The majority of pilots are never going to experience something like an engine failure, but they all simulate these types of environments over and over repetitively so that if, God forbid, it does occur, they're able to respond appropriately and actually have some true experience in dealing with these types of situations. It's also being used in medical education in general surgery, as well as emergency medicine in particular. These are two of the fields that have a lot of simulation. A lot of other fields as well, internal medicine, other procedural skills fields are starting to adopt a lot of simulation education as well. Ultimately, the goal is to recreate some degree of a high stakes learning environment where you feel some of the pressure and are able to better understand what's going on without having high stakes for the patient. So, there's no real lives at stake or any morbidity that can occur in the learning environment. So what's the utility of this? There was a paper published at actually the Mount Sinai Journal of Medicine a few years back that discussed that some of the benefits of medical surgical simulation are to engage adult learners. So adult learners in particular need to know why they're doing things. They need to have some agency in what they're doing in order to really buy into a learning curriculum. It allows for deliberate practice. And like I said before, it has been widely used in general surgery specifically, but also in a number of other surgical specialties. One of the things that I think drew me to this is that it fulfills a part in the Kolb learning style and experiential learning cycle of active experimentation, so doing. And this is something that's specifically good for people who are converging style learners or prefer a converging style of learning, as you can see in the bottom left corner here. So this surgical simulation allows us to actively experiment. So people who like to transition from thinking to doing are able to do that. And I think this appealed specifically to me. This is actually my Kolb learning inventory that we took for the course. As you can see, I'm a very converging style learner. And that's actually mirrored a lot in the literature. So about 50% of first-year orthopedic residents at one institution they looked at demonstrated converging learning style. This is mirrored in general surgery, plastic surgery literature. I think surgical specialties in general just appeal to these types of converging learners, and simulation allows them to learn in a way that suits the learning style that they find most natural. So the benefits of near-peer education. It's a little bit of a lower pressure environment when it's your peers and not attendings there. You're better able to ask questions, feel comfortable making mistakes, be able to explore a little bit more. The teachers are closer to the learners in experience, meaning that they're better able to understand the perils and pitfalls that an early learner could be experiencing. An expert teacher, for example, may not remember how they're moving their fingers when tying knots. They just tie knots automatically, whereas a newer kind of practitioner would be better able to explain that. There are also educational benefits to teachers. People who haven't fully mastered their craft yet are able to pick up a lot more from teaching it to other people than, say, experts in the field. And then pragmatic concerns. So attendings often have things pulling them in a lot of different directions, whereas sometimes senior residents have more dedicated time for teaching, less external influences there. There is some evidence that near-peer teaching, especially in the orthopedic curriculum, provides significant benefits over a traditional teaching style. So compared to textbook reading and a live demonstration of physical exam skills, this paper published at NYU demonstrated that near-peer teaching, when assessed with an OSCE, allowed better acquisition of physical exam skills in orthopedic residents. Additionally, there was non-inferiority shown between senior resident and attending-led cohorts when doing a simulation for plunge depth, which is kind of one of the simulations that we're looking at teaching in our curriculum. So this demonstrates, kind of concrete evidence that near peers can teach just as well for these basic skills as attending practitioners. We're not losing much here, or we're gaining some things and not really losing anything in terms of results. So one of the good things about our program, we already have a framework in place for this. We have weekly education sessions for the interns on Wednesday mornings. And there are PGY 4 and 5 led sessions that were already being used before I kind of stepped in to start working on this. We have a total of 14 senior residents. So the next steps of this, we're developing a curriculum once we establish that this is something that I wanted to work on. These are current 6 steps of curriculum development, which we'll kind of go through as it went with my curriculum development for this. So the first step is a general needs assessment. This was fortunately already done for us, kind of. The ABOS, American Board of Orthopedic Surgery, and the ACGME instituted some changes for the PGY1 intern year curriculum in 2013 and got a bunch of experts together to create modules to guide curriculum development. These modules, although very extensive, weren't really adaptable to every type of situation. There are some that called for, multiple cadaver labs. There are some that called for a lot of other things that weren't always going to be applicable to every residency program. And that's part of why these modules were created, was to be a framework for each program to develop their own curriculum. So the next step, a very important step in curriculum development, is a targeted needs assessment. Though we tailored this to our intern class, this can really be tailored to any group. Once you have a general needs assessment, you can do a targeted assessment. Say, for example, if we want to do simulation for PGY 4s and 5s, we could do a targeted assessment to see what specific things we could do in creating a curriculum for that group. We got our stakeholders involved in providing feedback on what they thought that the interns could do better, or the PGY 2s needed work on coming into early PGY 2 year operating. These are kind of some results that we have. You can see there are a few things like suturing and knot tying that are pretty unanimously agreed upon. Intramedullary nailing, another type of procedure. And taking that data and with the attendings running our current curriculum, I created 10 pilot sessions that we're going to be using this upcoming year in order to start instituting a near-peer teaching curriculum using surgical simulation. These are learning guides that we've developed specifically for our curriculum. So they kind of adapt the modules that were provided by the ABOS and create much more structured framework of, like 10 minutes for this session, 10 minutes for the next session, something that's going to be very easy for the senior residents to follow and institute. And each of these are reviewed with the interns, PGY2s, and attendings prior to make sure that there's nothing missing from these that they think that would be valuable in some of these teaching sessions. The next step would be educational strategies in developing a curriculum. So for ours, we're going to be very heavily focused on simulation, but I wanted to make sure that we did a lot of pre-work prior to the sessions so that the sessions themselves allowed our learners to get the most out of the simulation. So they have to review the ABOS modules beforehand. There's a few videos that are also included for them to review, some that we're refining currently. And then we're developing a pre and post test framework for each module as well. That allows us to get a little bit of assessment on the impact on declarative knowledge in our learners, which is something useful for refining our curriculum in the future. So unfortunately with COVID, we had a little bit of a delay in instituting this curriculum. So it all kind of started December 2019 with the Harvard Macy conference. We developed our initial project ideas. And then unfortunately, shortly after, all our intern education sessions were ended for in-person sessions, which kind of prevents us from doing hands-on simulation activities. And so we readjusted the timeline. We're going to be launching in July 2021 with the new intern class that's coming in, doing these 10 pilot sessions. We're continuing right now to refine our curriculum, review it with attendings and the current interns just to get their feedback on the design before we start to institute these pilot sessions. Hopefully by December of this year, we'll have completed these pilot sessions. We'll be able to go back through and adjust our curriculum as necessary based on feedback. Kind of our biggest next steps, and one thing that is unfortunately not very well developed in the orthopedic literature is strategies for evaluating the effectiveness of curriculum. So although we can have pre and post tests to evaluate declarative cognitive knowledge, one of the very important things that we need to develop are validated outcomes assessment tools to assess the technical skills gained. This is a publication that kind of reviewed the types of outcomes assessments that are out there, things from OSAT, subjective, structured assessments of technical skills, to CSATs, which are kind of the same thing with video recording and multiple people providing assessment, and then direct objective metric tools as well. So general surgery has a lot of these that are well defined. Orthopedic surgery is still working on creating these, and I think as part of this project, there's a lot of opportunity to create some validated assessment skills to see how our interns are picking up these technical skills, if they're performing any better after going through some of these surgical simulation sessions. I'd like to acknowledge Dr. Parsons and Dr. Yulin, who have been the two attendings and leadership in my program that I've been working with very closely in developing this. I'd like to acknowledge everyone who helped us at the Institute of Medical Education, as well as at the Harvard Macy conference in terms of the teaching. All the sessions were excellent, and I really appreciate the opportunity to go. And then I wanted to thank my small group mentor, Dr. Christopher Merritt. He was actually an emergency medicine physician there, who had a lot of experience with simulation, and we talked through our project idea and refined it quite a bit at the course itself. My contact information is there. Happy to respond to any emails. I know there's going to be a feedback that's also going to be available at the end of this talk. And that's me with my wife, who is an emergency medicine resident, actually. So we talk a lot about, she's going to do a simulation fellowship. We talk a lot about this at home. And then the guy in the middle who's marrying us is my best friend from college, who's a pilot. And he and I talk a lot about our simulation training and what they have that we don't, what we have that they don't. So it's kind of a, this group of people is really what inspired me to go along this path, and it's been something that's been really rewarding for me.
Thank you so much, Kevin. I see a question from Dr. Lightman. Mike, can we hold the questions till the end? We just want to make sure that Dr. David has time, and then we'll get to all our questions at the end. Thank you so much, Kevin. We'll move on to Dr. Yakira David.
Okay, that was a fantastic presentation, Kevin. And I really want to echo a lot of the sentiments that you expressed about our gratitude for the opportunity to showcase and discuss our work here today, and really for the support that the IME has given us to allow us to attend the Harvard Macy program, which really provided a strong foundation and lots of tools to equip us to not only refine these projects, but will certainly help us moving forward in our medical education careers. So my talk today is on a project that I did that focused on formative assessment for endoscopy-oriented clinical reasoning. I have no disclosures. So for today's talk, I'll discuss clinical reasoning and give you the background for our project, discuss the methods that we use to develop and implement our tool, the metrics that we monitored, and the next steps for this project. So similar to Kevin, I'm in a bit of a procedural field. And clinical reasoning, as you're probably very familiar with, is used in all spheres of medicine. And it's used by practitioners to collect data to understand the patient's medical problem and incorporate that data to generate and test hypotheses. We then use that to develop and refine our differential diagnoses and then institute appropriate management. Now, a lot of the medical education around endoscopy has focused on the technical aspects of endoscopy. And there really isn't a tool or process that's been found that exists that provides structure for assessing and teaching clinical reasoning. With endoscopy, that's a new tool that's introduced to us in fellowship. Now, within the endoscopy workflow, there are two areas that naturally lend themselves to clinical reasoning discussions. The first is at the beginning of the procedure, where clinical reasoning discussions can occur that focus on the indication for the procedure and what the actual clinical question is that needs to be answered by this procedure, what the differentials are for this particular clinical scenario, what the anticipated interventions are and any preparation that's necessary for that, as well as the pre-procedure optimization of the patient. Now, at the end of the endoscopy procedure, by the attending providing feedback to the fellow on the endoscopy report, this is another opportunity for clinical reasoning to ensure that the fellow's impression that they document on the endoscopy report actually incorporates all of the findings of the procedure and then uses that to answer the clinical question that was initially posed in the indication. Additionally, fellows should also be incorporating the findings to provide further recommendations of management of the patient based on their findings. So for our needs assessment, we asked fellows, how often within your standard endoscopy workflow is any of this happening? The majority of our fellows, 55% of them, indicated that pre-procedure discussions happened in general about half of the time. And only 27% of them reported that this was happening most of the time. Our results for the endoscopy report feedback are even less promising, with only 46% of fellows indicating that they received endoscopy report feedback about half of the time, and up to 36% of them reported that they rarely received any feedback on their endoscopy reports. We also asked our faculty. We selected a small focus group of 4 GI attendings who are heavily involved in endoscopy precepting, and we asked them, based on the last 10 procedures that you did with fellows, how often did you notice their endoscopy reports incorporating impressions and answered the clinical question, or made recommendations for management based on the findings of the endoscopy? And they all thought that this was happening only 50% of the time. Now, while this is a retrospective survey and very prone to recall bias, we took these responses to indicate that there really was a need to develop some sort of structure and process to teach and assess endoscopy-oriented clinical reasoning. And that was the goal of our project. We wanted to develop a process for formative assessment of gastroenterology fellows' endoscopy-oriented clinical reasoning thought process, and then take it a bit further to develop the documentation of this clinical reasoning in their endoscopy reports. Now, there are a number of tools that are available for assessing and teaching clinical reasoning in the literature. And chart-stimulated recall is one of those techniques, and we thought that this would be particularly applicable and helpful for our goals for endoscopy-oriented clinical reasoning. Chart-stimulated recall is a validated process whereby you use an actual medical encounter, and it has two components. The first component involves an audit of some aspect of the medical record, which in our case was the endoscopy report. That's coupled with an oral structured interview where the fellow is interviewed about different components of their thought process through their clinical reasoning for that particular case. Now, there aren't any tools that are in existence for endoscopy specifically. So we had to tailor the chart-stimulated recall tool and adapt it for it to be applicable to endoscopy. To do this, we formed a focus group of the same 4 GI attendings who are heavily involved in endoscopy precepting. Using a nominal group technique, we formed a consensus on the baseline endoscopy report requirements, and then used that to develop worksheets. We had 2 worksheets, one focused on auditing the endoscopy report, and the other contained components to conduct an interview to assess the fellow's clinical reasoning through the case. Now that we had those 2 worksheets, we then selected 3 cases and simulated an interview between an attending and a fellow. Each of the attendings in the focus group scored the individual components of the worksheets, and then we did comparisons and further refining of the questions to improve our inter-rater concordance. At the end of those 3 cases, our CAPA scores indicated that we had fair inter-rater concordance for the interview component worksheet and moderate inter-rater concordance for the endoscopy reports. And this is our final product. So this is the worksheet that we use to audit the endoscopy reports. As you can see, it's measured on a 3-point Likert scale, ranging from 1 of the component not being documented at all in the endoscopy report, 2 with it being documented but incomplete or incorrect, and 3 with the component being clearly documented and comprehensive. Some components are not applicable to all cases, and there was an option to score that as well. For each of the components, we included prompts as well as examples to help guide the auditor. We focused on documentation of the indication for the procedure, such that it captured the clinical question that needed to be answered appropriately, the equipment that was used, the rationale for obtaining any biopsies, comparisons to prior endoscopies or any pertinent imaging, appropriate use of standard classification systems, clear differentials for any abnormal findings, an impression that incorporated the findings of the endoscopy and answered the clinical question that was mentioned in the indication, as well as plans for additional investigations that were needed, changes to medication management, anticoagulation management specifically, as well as photo documentation, such that it captured all of the key landmarks, as well as any pertinent clinical findings. This is the worksheet that we used for the interview. As you can see, all of these components mirror those of the endoscopy report, but this really allows for a structured discussion about the fellow's thought process for each of these components. And this again was scored on a 3-point Likert scale. Now for the actual implementation, we did this in 3 steps. So firstly, we used the worksheet for auditing the endoscopy report. We selected 4 cases per fellow that had been done in the 1 to 3 month period prior to the institution of this intervention. We scored each of those reports using our endoscopy report audit worksheet. We then conducted a chart-stimulated recall interview session with each fellow, and I'll go into detail about what that actual session entailed. After each fellow had done at least one of these interview sessions, we then repeated an audit of our endoscopy reports. We again selected 4 reports per fellow, and we did this in the 1 to 3 month period following implementation of the intervention. For the actual chart-stimulated recall interview session, it went as follows. Firstly, we selected another case in which the fellow had done both the initial consult as well as the actual endoscopy. Prior to coming to the session, we asked both the fellow and the attending to independently review the endoscopy report and score it using the endoscopy audit worksheet. This is a step that's unique to our chart-stimulated recall process. Other standard chart-stimulated recalls don't incorporate that side of that element of the fellow or the trainee doing any auditing of the report. And we thought that this was important to foster self-reflection by the fellow, and it can also be used as a tool longitudinally for self-directed improving and assessing of your clinical reasoning and your documentation of it. Then the attending uses the interview worksheet to interview the fellow and go through the different components of their thought process through the case. And at the end of the session, the attending would then provide feedback to the fellow on their responses in the interview, as well as on their endoscopy reporting. This entire process takes about 20 minutes, and we typically did 2 cases per session. And the goal is to repeat this at 3 monthly intervals and thereby be able to trend fellows' improvement in their clinical reasoning throughout their fellowship. In terms of measuring the impact that this intervention has been having, we first asked our fellows what they thought about it. Since participating in this exercise, all of our fellows thought that this had a positive impact on their pre-procedure thought process. This positive impact was mild for 50% of them and significant for 50% of them, but they all deemed it as being positive. No one had a negative impact after doing this exercise. When asked how often their impression now answered their clinical question, all of them reported that this was happening in 76 to 100% of the reports that they were writing. When asked how often they conveyed recommendations in the endoscopy report clearly, the majority of them, 75% of them, reported that this was happening in 76 to 100% of their reports. And when asked whether they thought that this exercise should be incorporated into part of our standard curriculum, they all agreed that it was beneficial and they would like to keep it. Now, in terms of assessing our fellows' learning, the component we chose to focus on was on their responses in the endoscopy interview. What we found interesting was that our fellows scored really well on the interview component of this exercise, with median scores of 93%. For a given session, the endoscopy report scores, however, were not as good. They were 70%. And we took this to indicate that our fellows do have a good baseline clinical reasoning knowledge, but there is in fact a gap in the practice of documentation of this in their endoscopy reports. In terms of looking at their behavior, which we took to be the actual practice of documentation of clinical reasoning in the endoscopy reports, we did a comparison between their pre-intervention endoscopy report scores and their post-intervention endoscopy report scores. Now, prior to intervention, the areas that they scored the lowest in were on recommendations post-procedure for management of medications as a whole and anticoagulation. After doing at least one chart-stimulated recall exercise, there was a significant improvement in reporting of these components, such that they were clearly documented and comprehensive. There was one area that we really didn't see much improvement in, and that was in prior study comparison. And that's an area that we need to continue to work on and emphasize with our fellows to ensure that this is incorporated in the endoscopy reports. 2 additional areas in which there was documentation of some variety, but that we thought was particularly important to place emphasis on, were in the indication for the procedure and the impression to ensure that it incorporated the clinical findings and answered the clinical question. And for both of these were usually present in the endoscopy report before we did our intervention, but at times were incomplete or incorrect. And we did see an improvement in that as well in our post-intervention endoscopy report audits. And overall, the scores that we found on the median score for the endoscopy reports before intervention was 74%, and this improved to 83% after we had done our intervention. So in terms of assessing our intervention, the impact of our intervention, we really tried to design metrics that addressed each of the levels of Kirkpatrick's pyramid. We don't have a metric that specifically assesses the pinnacle of the pyramid, but our hope is that by addressing and improving each of these other components, we ultimately would result in achieving improved pre-procedure optimization of our patients, improved diagnostic accuracy, and improved development and communication of post-procedure plans. We thought this was a beneficial exercise, and we don't want to keep it just to our fellowship, and we're hoping to disseminate it to other programs as well. To do so, we created a comprehensive endoscopic chart-stimulated recall faculty development package. This package includes the worksheets that I showed above for the interview, as well as the chart audit of the endoscopy report, a faculty guide that goes over the process and provides a script to aid with conducting the interview. And finally, it contains an instructional video that goes over the entire process, walks you through the stages of conducting the exercise, goes through the worksheets, and then finally provides a live demo of an actual case. So in conclusion, we do think that there is a need for a structured format for assessing and teaching clinical reasoning as it relates to procedures. We found that chart-stimulated recall was an effective tool for this purpose. You can modify it, as we did in our exercise, to promote self-reflection and enhance self-directed learning. And while we thought it was effective and doable, it does require dedicated time and buy-in from fellows and faculty for it to be successful. I have lots of people to thank who helped me along the way with this project. Again, I'd like to thank the IME. I'd like to thank the American Gastroenterological Association Academy of Educators, who provided me with a modest grant to help with development of the video. I specifically want to highlight my mentor, Bridget Shaw, who is the best mentor that anyone could ask for, who has worked with me tirelessly to develop this project and to keep the steam going with it. I'd like to thank the other members of my faculty group, which is Satish Nagula, Cameron Palmer, and Pascal White, my program leadership, Dr. Sands and Dr. Itzkowitz, my program coordinator, for helping us get all of the equipment that we needed for faculty development sessions, my co-fellows, Noah Dirks, who did my video, and my Harvard Macy focus group. And I'll be happy to take any questions afterwards. Thank you.
Great. Well, unfortunately, Dr. Karani had to step away. She asked me to step in her place. I want to start by thanking both our presenters for incredible presentations on great projects. We look forward to seeing what happens with these in the future. We're going to open up for questions now for either presenter.